So I was going to talk a little bit about some research we've been doing looking at cardiac and renal crosstalk as it relates to mechanical support. This is an area that I think impacts a lot of our patients clinically and is still sort of undefined in terms of mechanism. So one of the things that we've been looking at, especially in the era of the door to unload study, is the impact of kidney injury on long-term outcomes after acute MI. And this is a paper that was put out by Harlan Krumholtz and his group back in 2008, showing that even with mild acute kidney injury in the setting of acute MI, the long-term implications of that for mortality are actually pretty astounding. And in fact, of course, with more severe AKI, the earlier mortality rates are also noted within 30 days. There's an association between AKI and outcomes. We also know more recently that there's an impact of transient kidney injury as well, that it doesn't have to be permanent damage to the kidney, but even if you have mild transient AKI, whether it's mild, moderate, or moderate to severe, even transient AKI in the hospital still has implications for probability of death. And so I think that's an important observation that was made in 2009. And more recently, this analysis came out looking at over 500 patients with NSTEMI and STEMI, and again, looking at outcomes, looking over a number of years. You can see that in the upper right panel, the patients with AKI, any evidence of AKI, had a significant increase or a spike in mortality in that short-term period within the first 30 days, and then that continued out over 10 years. So what we know about kidney injury so far has been probably best validated in the heart failure models. And so if we think about the mechanisms of kidney injury and heart failure, this usually has to do with two possibilities when it relates to kidney perfusion. One is an increase in renal vein pressure due to congestion, which Dan talked about earlier. The second is hypoperfusion, leading to low perfusion of the kidney. And of course, this concept of the congested kidney or nephrosarca is something that has been governing heart failure management of AKI. We also know that there's a change in terms of glomerular filtration rate. So Dan mentioned the head scratching comment of the disconnect between GFR and urine output. And this is some of the illustration here illustrating how even the drugs we use in heart failure may also have an impact on GFR as well as urine output. And then, of course, there's this interesting phenomena of actually interstitial pressure within inside the kidney itself. And if you can imagine the kidney sitting inside a capsule and becoming more and more congested, it also starts to develop essentially the equivalent of a compartment-like syndrome, where now you start to see the tubules themselves collapsing because of increased interstitial pressure in the overtly, chronically congested heart failure patient. So one of the things we've been studying is the impact of acute mechanical support devices on renal function. And we simplistically put this out at TCT a couple of years ago, this idea of the pusher and the puller. And the pusher, of course, are the ones that increase renal preload, which is arterial. And I'm putting this in cardiac speak so that we're not speaking with nephrologists when we say these things. And then, of course, renal afterload is actually looking at renal vein pressure as well as flow. And so if you think about the different technologies, Impella may increase renal preload by increasing arterial perfusion. VA ECMO may do the same. Reduced renal afterload, maybe the Impella RP reduces renal vein pressure. Tandem RVADs or VA ECMO may do the same. So we didn't have enough data really in these domains to understand what is the impact of these pumps on renal blood flow. So what we do know is that if you are looking at the ECMO literature, there's about a 60% incidence of acute kidney injury with initiation of VA ECMO, and that this also correlates with survival, that patients who have severe AKI also have lower survival after initiation of VA ECMO. And there have been a number of review articles, and this is one that was pretty comprehensive, looking at postulated mechanisms for renal injury in the setting of ECMO. And they can be broadly categorized into hemodynamic variables, hormonal variables, and of course, patient variables. And if you look at the hemodynamic variables, it talks about loss of pulsatile flow, changes in cortical and medullary flow, and then of course, renal oxygen delivery. And so this was a perplexing graph to me as I was trying to wrap my head around what ECMO might do to the kidney. And then, of course, this paper came out a couple of years ago. This is from Mike Flaherty and his group, looking at renal protection in high-risk PCI with Impella. And I think a lot of people also are still scratching their heads about these pretty astounding data, looking at the fact that patients who did not have mechanical support with the Impella undergoing high-risk PCI, if they had any evidence of AKI coming in or impaired renal function, there was a spike in the proportion of patients developing AKI. But in the yellow bars, the patient who had Impella, even 2.5 support, started to show lower proportion of patients developing AKI, even if they presented with moderate estimated GFR impairment coming in for high-risk coronary intervention. And the mechanism underlying this, again, is still fairly poorly understood. And this is the courtesy of Ralph Westenfeld, who's been doing a lot of pioneering work, and Protect Kidney is something that we'll hopefully learn a lot more about from Ralph. But he started looking at patients who received Impella versus VA ECMO and started to show, again, this association of an increase in creatinine patients on VA ECMO, but really no evidence of this increase in creatinine for patients who are supported with Impella, even over a period of days. Now, the few studies that I can find looking at renal blood flow, this is one of them from 2015. This is from Muller, Helgestad and his group, and the group in Denmark, basically looking at changes in renal blood flow with intra-aortic balloon pump versus with Impella 2.5. And what they suggest is that there's a signal of increased renal blood flow with Impella, but with balloon pump, you see no change compared to baseline. So we decided to take this into our animal lab, and Laura Raelt and Paige Crowley are our two preclinical surgeons who do a lot of our work, so we appreciate their work quite a bit. And this is one of the examples of the physiology module we've started to set up. So in order to understand flow dynamics through the kidney, we figured that we would have to have pressure and flow measurements in the renal artery as well as the renal vein. And we would also need to have some measure of intraparenchymal pressure. So we started to look at flow wires positioned in the renal cortex, both on the arterial side as well as on the venous side. And this is the overly ambitious setup from the lab, basically looking at a number of consoles. We've been using volcano wires, like they basically cost nothing, which they don't. And we've been using a lot of pressure wires, and the team has gotten really good at placing all of these components in a rapid fashion. So this is some of the data that we've been looking at. What you're looking at is renal artery flow velocity tracings. And up at the top, you can see baseline, and after 6 hours of just no pump, just being anesthetized for 6 hours for the pig model. And in the middle panel, you can see FEM-FEM VA ECMO. So at baseline versus after initiation 6 hours later, a significant change in the diastolic peak flow velocity, and also the loss of pulse amplitude. And then also in the Impella CP at the bottom, after 6 hours of Impella support, we're starting to look at these flow profiles in more detail. And this is the first study that we started doing, was basically to just take healthy adult swine and sort of validate our renal module setup. These swine were then subjected to VA ECMO or Impella for 6 hours, and we monitored all of these hemodynamic variables as well as cardiac variables. So in the black bar, what you can see there on those points across the 6 hours is just the sham control. That's cardiac output, stroke volume, and systemic vascular resistance has a slow degrading point over a period of 6 hours. Now, after we initiate VA ECMO, this starts to look a little bit different. You start to see a drop in your native LV cardiac output, as you might expect. But what's interesting is this change in systemic vascular resistance. So these are ECMO pumps that are flowing at about 5 liters per minute. And what we expected to see was sort of this engorgement of the arterial circulation. But what we started to see actually, even within the first 30 to 45 minutes, is a profound drop in systemic vascular resistance. And then this persisted over the 6 hours throughout the treatment period. And in contrast, when we applied the Impella in this environment, what we saw was that LV cardiac output was maintained, stroke volume was maintained, similar to the healthy animal heart, and that systemic vascular resistance also started to parallel sham control. So important differences between SVR response on VA ECMO compared to Impella CP support. And then, of course, the question is what happens to the kidney? So remember, we're trying to understand all of the renal dynamics. And what we can see here is that the kidney itself has a really amazingly built-in system of autoregulation for pressure management. So when you look at renal artery pressure, actually, all of the curves start to align and don't really change too much. But the story starts to become interesting when you look at renal artery flow velocity. And so remember, what we saw in the control in the black points was a slow decline in SVR, and in the Impella group, we saw similar to control. But in VA ECMO, as SVR is going down, what we started to see was that there was an increase in arterial flow velocity. And this increase in arterial flow velocity also correlated with this loss of renal arterial pulse pressure. So when we look at that pulse pressure that we showed in those tracings, now we're looking at pressure instead of flow, we see that there's a loss of pulsatility both with the VA ECMO and the Impella circuits and compared to sham control. So these are some of the earliest findings that we're beginning to see. It's relatively early preliminary data, but we're very curious to see what happens over time. And in the renal vein, we actually didn't see much change at all across the three groups. The renal vein was relatively preserved. So one of the things that we've also been looking at is the fact that the kidney itself acts as a sensor for systemic pathogens as well as damage-associated proteins. And so if you think of the renal cortex where all your glomeruli reside as filters that are basically sensing anything that's going on in the bloodstream, this occurs in sepsis, for example, that's where these illustrations are taken from, you can see the release of these DAMPs and PAMPs, so damage-associated molecular patterns and pathogen-associated molecular patterns. And as they filter through the glomerulus and start to go into the renal tubules, the proximal tubular epithelial cells are very much like the epithelial cells in your nose. They essentially can detect smells. And so the kidney can actually sniff out these pathogens and these circulating markers, and then they activate a signaling mechanism inside the renal tubule itself, which starts to trigger and tell the body, and especially tell the kidney, that we may be experiencing injury. And you can see in there in that illustration on the right, some of the markers, things like TNF-alpha, are also implicated. Now, this is another important paper that looks at the importance of clinical AKI. So when we look at these markers, there are functional markers and there are damage markers. So functional markers may be things like creatinine or GFR, something that's functionally indicating how the kidney is doing. And the damage markers would be things like biomarkers that are released that suggest that there's kidney injury. And when you have an insult, there's an increase in that injury pattern, but at the same time, the kidney has a profound reparative response that parallels the injury response. But what happens is over time, with the duration of injury, those two curves start to separate. And when they start to separate and you have more injury than repair, then you start to develop this more permanent injury, and that starts to lead to renal fibrosis or more chronic conditions. And that's when AKI transitions to chronic kidney disease. So when we started to look at whether or not we can gain some insight from these models, the question was, are we looking at functional markers or are we looking at damage markers? And these are two damage markers that are well established in the literature: kidney injury marker molecule 1, KIM1, as well as neutrophil gelatinase-associated lipocalin, and that's NGAL. And KIM1 is particularly interesting to us because it has this large extracellular domain. It's implicated in AKI more so than with CKD. And this is shown here that you can see the spike in KIM1 expression. This is in various preclinical models, as well as it's been established in human models, that AKI starts to associate with KIM1, whereas NGAL starts to associate with chronic kidney disease. And the KIM1 biomarker itself actually gets shed. So KIM1 resides on the proximal tubular epithelial cells. When there's an inflammatory response or metalloproteases start to get released, KIM1 gets cleaved and then gets put into the urine, and that's how you detect it, is in the urine itself. So when we looked at our preclinical models comparing primary reperfusion versus primary unloading versus VA ECMO before reperfusion, we had collected urine and plasma from all of the animal models at different time points throughout the study. And our initial pass showed that we started to see in the red bars, just with ischemia reperfusion injury alone, that there was a significant increase in urinary KIM1 levels in the pig model. And when we initiated Impella support in blue, that the unloaded animals actually did not have this increase in KIM1, but in the VA ECMO model, we again saw that urinary KIM1 levels were elevated. Now, circulating KIM1 levels didn't really change too much, and that's not surprising because remember, it relies in the tubule itself and it gets shed into the urine. These are the NGAL levels, which also didn't really quite associate it. We did see a spike in urinary neutrophil gelatinase activity with ECMO, but not with Impella or with IRI alone. So the question then became, what is the functional role for KIM1? So we know that KIM1 gets shed, but the question is, does it actually do anything in the kidney itself? And this is the canonical signaling pathway for KIM1 that's been taken from the oncology literature looking at renal carcinoma cells. And when KIM1 gets shed, it binds to a receptor, and then it drives expression of IL-6, which is a potent inflammatory cytokine. IL-6 can then activate downstream signaling through STAT3 as well as HIF-1 alpha. And so we started to look at whether or not our model was seeing the same activation of KIM1. So here, for example, we're showing that in the sham model with IRI, we see that there's a shedding of KIM1 into the urine, so there's a loss of that extracellular domain. With Impella, the KIM1 level is actually preserved, so it's not shed into the urine. And with ECMO, it is shed into the urine, similar to the IRI injured kidney. And when we started to look at MMPs, what we saw was something really interesting. In the renal cortex, matrix metalloprotease levels and activity were significantly increased just by having a heart attack. And this is in the renal cortex, so the kidney has the sensor there. And if you notice, if you look at the zymography in the Impella arm, there was no upregulation of renal cortex activity of MMP or even MMP levels. But in ECMO, again, similar to IRI, there was this increase in MMP activity. Now, what becomes really fascinating here is something that Doug Mann said earlier, is that if you have MMP activity in the heart, you start to dilate. But if you don't have MMP activity, you're unlikely to start to dilate and negatively remodel. So we started to look in the same animals at the renal cortex and at the infarct zone. And interestingly, they had the exact same pattern of expression. The MMP activity level and the protein level are massively upregulated in the ischemia reperfusion, but in the unloaded animals, we saw no expression or activity of the MMPs in the heart or in the renal cortex. And with ECMO, both were significantly upregulated. So this led us to question whether or not there was an inflammasome reaction that was occurring in these models as well. And when we started to look at the panel of inflammatory markers, IL-1 alpha, IL-1 beta, IL-6, TNF alpha, and interferon gamma, you can see that in the renal cortex, there were significant changes suggesting a hyperinflammatory environment in the renal cortex. But in the heart itself, it was really restricted to IL-6 and TNF alpha in terms of this hyperinflammatory response to ischemia reperfusion injury. And across the board, the Impella group had an attenuation of that inflammatory response, both in the heart and in the kidney. And of course, we looked at circulating levels of these factors and found that plasma TNF alpha and IL-6 were also elevated, suggesting a connection between the heart and the kidney, especially under acute MI conditions. And then the downstream signaling of KIM1 also seemed to be upregulated by IRI, but protected in the Impella model and not protected in the VA ECMO model. And the downstream signaling, again, going one step further, looking at HIF1 alpha, also showed the same expression profile in the renal cortex. So what we find really interesting about these data is that actually there's an association then between heart attacks and renal cortical injury. And in fact, what we should be talking about is this concept of a renal attack in the set at the same time that you're having a heart attack. And the question is whether or not this cardioprotection afforded by the Impella is related to changes in renal flow dynamics, or is it actually coming from protection of the myocardium and shutting down this inflammasome that may filter down to the kidney itself. And then the downstream effect, of course, of having this upregulated KIM1 activity is shown here, this link between KIM1 and profibrotic signaling through TGF-beta in the renal proximal tubular epithelial cells. So our takeaway message is that there may be actually this crosstalk, and we're excited in the DTU pivotal study to start looking at some of these biomarkers and looking at renal injury as a protective readout in the Impella arm compared to the door-to-balloon arm. And this suggests that a lot of the activity here might be being driven by an inflammatory response coming from the heart as well as from the kidney. Thanks very much for your attention.
That was a fascinating presentation, as always. We're a little bit behind schedule, so in the interest of time, we'll limit ourselves to one or two questions from the audience.
Thanks very much for this very interesting talk. So, do you think it's only a matter of retrograde laminar flow, so hemodynamics and differences in flow support, or is it also a function of hyperoxygenation? Because most centers actually apply a VA ECMO with 100% oxygen, and I think it's not very healthy for an endothelial cell to have 500 square millimeters of...
Yeah, so there's a lot more data here than I could possibly show you today, but we do think it's actually both. We think that the fact that with FEM-FEM ECMO, you're pressurizing the arterial renal artery itself, you're changing the flow dynamics, and over a period of time, what we think is happening over 6 hours is that we're exhausting renal autoregulation, and that the autoregulatory mechanisms start to fall apart. And that's why we see that flow velocity start to increase towards the end of the 6-hour period on ECMO, but we don't see that exhaustion of renal autoregulation with the other pump technologies. And then in terms of the hyperoxygenation, I think I agree with you. I think that there actually should be a target of normoxia as opposed to this immediate response of just going to hyperoxia. And my guess is that's driving the ROS response and a lot of the inflammatory response that we're seeing, which may be actually driven by innate immunity as opposed to cellular immunity.
Great, thank you very much.
Thanks, Navin, for this beautiful talk. Maybe one final comment. We are really excited that we got ethical approval now for PROTECT kidney trial, yesterday actually. And so we will have a trial where we just treat patients with Impella, usually not in shock and not in, we can do it in ACS, in order to protect the kidneys. And I think at first glance, I put my money on this perfusion stuff. Like, I'm believing in diastolic perfusion somehow, which is remained by Impella. But your data are so convincing, and we should think at least about whether we can merge some data from DTU and also from the PROTECT kidney trial, where we don't have a clear-cut infarction, to dissect maybe what is the amount of myocardial injury going back to the kidney versus what is the kidney doing itself according to perfusion. So we may have 4 groups that we can gamble around with. I would be very excited about that.
Yeah, I think the PROTECT kidney trial is going to really open up a whole new space, and I suspect you're going to see a lot more renal perfusion data and questions that come up. So as long as there's a biomarker arm in PROTECT kidney, I think we'll start to get some more insight into mechanism. Thanks very much.
Thank you very much.